Well, my computer clock says 12 noon on the dot, and in respect for everyone's time, we will go ahead and get started. Good afternoon. For those of you who don't know me, my name is Brenda Roberts. I'm the Director of Quality Assurance and Education with Michigan Assisted Living Association. On behalf of MALA, I want to thank you for joining us for today's discussion and that we hope you will find it beneficial. Clearly, long-term care communities have been devastated by COVID-19. Less than 1% of Americans' population live in long-term care communities, but the death among this population accounted for approximately 1/3 of all COVID deaths. In all, approximately 8% of people living in long-term care communities has tragically died from COVID-19. COVID-19 continues to show the world what we've always known. Infection prevention is key to keeping communities safe and healthy. This week is International Infection Prevention Week, and MALA is proud to partner with Active Pure Medical to host a two-part educational web series on infection prevention in assisted living communities. MALA represents senior living facilities throughout the state who provide services to more than 42,000 older adults and individuals living with disabilities. Active Pure Medical is part of a 95-year-old legacy of companies with a deep history in cleaning and disinfecting. We've also been talking with a number of state legislators about this effort, and we have a special message from one of them for you today.
Hello, and thank you for joining this course today. The work that you're doing every day on the front lines, keeping people safe, trying to control infections is incredibly important work. And so I really appreciate you spending some extra time to participate in this event today. And I just want to tell you what a big difference it makes when we've got folks who really care, who are out there, who are every day keeping people safe. It's especially important now with COVID. It's really in our face, but this is something that's been important all along. And your efforts every day, keeping people safe from infection, is keeping people alive. It's keeping people healthier and happier for longer. And it's greatly appreciated. So thank you for everything you're doing, and thank you for being here today.
Great. Well, we have an excellent lineup of speakers for you today, and I'm going to introduce you to our moderator, Ambassador Jim Glassman, and then give him the floor to introduce our panel. Jim Glassman is a former U.S. Undersecretary of State who's been deeply involved in public health issues for the past 20 years. He had a long career in journalism as publisher of the Atlantic Monthly, editor of the congressional newspaper, Roll Call, and the host of the weekly CNN program, Capitol Gang Sunday. Thank you for joining us today. Jim?
Thank you so much, Brenda. And it's great to be here. And I'm glad we have so many people who will be listening to this webinar. I just want to say to start that on October 12th, Brenda was featured in an excellent article that I read in the Wall Street Journal in her capacity as Executive Director of the National Council of Dementia Minds. And I hope you all will read it. And congratulations to you, Brenda, and to your husband. As Brenda said, this is an International Infection Protection Week. And as most of you on this webinar know, America's nursing homes and other long-term care facilities have borne the brunt of the COVID pandemic. With fewer than 1% of the population, nursing home residents account for 1/3 of all COVID deaths in the United States. And among people in nursing homes, 1/10 have died of COVID as of March. These facilities face unique challenges. Prior to the pandemic, the Government Accountability Office found that nationwide, from 2013 to 2017, some 82% of nursing homes surveyed were cited for infection prevention and control deficiencies. Now, the vaccine is helping, and you're going to hear from the experts in a second. Nationwide, 85% of residents were fully vaccinated, as of October 3rd, as well as 69% of staff. And as for Michigan, last month, Governor Whitmer proposed $39 million for infection control in nursing homes as part of her Michigan Healthy Communities plan. And that includes money for improvements to make interior air safe. Next, you'll hear from John LaRochelle. John is president of Lighthouse Environmental Prevention, where he heads a team of experts dedicated to ensuring safe facility environments. John was formerly global leader for environmental infection prevention at Sodexo, the giant services and facilities management company. And after the two presentations, we will have questions from you. You can send them to us now or at any time through the Q&A button at the bottom of the Zoom page. I just want to say that this webinar is not to be copied by anyone here. And we are doing a recording, but that's just for internal purposes. So don't forget to send us questions at any time through the Q&A bottom at the bottom of the Zoom page. I'm going to turn now to my friend, John.
Okay, thank you, Jim. And again, my name is John LaRochelle, and I actually started my career as a housekeeper in a skilled nursing facility on long-term care. I went on to be a manager for many years as a director of housekeeping, facilities management, and laundry in a long-term care facility. So I'm very passionate about this very vulnerable population that we have and keeping them safe. So what I'm going to do is I'm going to go through some slides, and we look forward to your questions today. But one of the first things that we are posing and talking about is, are you effectively eliminating these harmful pathogens, whether it be COVID or other organisms, on the surfaces and in the air? Next slide. So when you look at the sink and when you look at any surface, when you look at the air, how do you tell it's biologically clean? When you look at things, a lot of times they look clean visually, but as you look in the bottom left corner, you can see that there's a very high count of active organisms and pathogens on these surfaces that need to be mitigated. So, the analogy I want to use next is, tragedy leads to change. I fly around the world for a living, and, when 9/11 happened, airline industry and security protocols changed forever for, the right reasons. So now when you apply that to COVID, next slide, you'll see that, we absolutely need to change and mandate change to the environment, how we clean, how we disinfect, how we perform hand hygiene, all aspects. And COVID is not a one-time event. It's here with us. It's going to be here with us a while. But cold and flu, pneumonia, norovirus has just as many infections and deaths. And these things are going to continue. And then there's future risks of other pandemics. So we need to change and adapt the way we've been going about this. This is absolutely our war on pathogen. We've had our war on terrorism, war on drugs. We're now in the war of pathogens, and there's nothing more important than keeping your family members, whether it's a young child, whether it's, certainly your elderly, and, our elderly population is very vulnerable, especially in these long-term care facilities. So we need to have diligence and structure around how we approach this. So let's talk about some of the common challenges. I'll go through these quickly. There's just a few examples I wanted to show you. But in this first study, it was done by Dr. Charles Gerber at the University of Arizona. They inoculated the front door of an office building that had 80 people. And then the next slide, you'll see where, how fast this pathogen actually traveled through the building. Thankfully, it was a harmless pathogen, but within 4 hours, 50% of the population of that office building had that pathogen on them. So it just shows how fast things travel. The next one is a study done by Dr. John Boyce. This was out of one of the Yale hospitals. And the first Petri dish shows the amount of pathogens on a surface before cleaning. The next slide shows that the problem actually got worse. So understanding the foundation of what's going on in your environment, that cleaning, disinfection, whether it can be surfaces or the air, can become worse unless we have the right process in place. This is another study done by Dr. Philip Carling out of Boston University, and he studied 23 acute care hospitals and found that only 49% of the surfaces were actually wiped on a daily basis by housekeepers. Next slide is the reason being is people are visually cleaning. I can tell you as a former custodian, I'm visually cleaning, and you can see what a phone looks clean. You know, when you look microscopically, you'll see that there's pathogens, whether it's on the phone, whether it's on the other high-touch surfaces. These pathogens are absolutely present. And they live a long time. COVID can last days to weeks. There's different studies and information, but MRSA, which is present everywhere in our environment, we've studied this, whether it be in homes, hospitals, especially in long-term care, can last active on a surface for up for 9 months. C. diff, 5 months, which certainly is a challenge, those two pathogens in our long-term care environment. And then the floors. You know, we were always taught the floors were not a problem, but in this study done by Dr. Curtis Donsky, he inoculated rooms, patient room floors, and studied where those pathogens went over time. Amazingly, 62% of the patients had that pathogen on them within 2 days, and then 62% of the surfaces, and the pathogen had started to travel. So best analogy I can use is you're in a room on a sunny day, those dust particles are floating in the air, they're hitting the ground, they're grabbing these pathogens, recirculating through convection and normal travel. So this is absolutely a challenge that we need to address and better understand. And then disinfectant failure points. You know, one of the key things we focus on, and when we're out working with any type of organizations, is how they're using disinfectants. And I can tell you how we use disinfectants are, you know, disinfectants are used inappropriately all the time. They don't meet contact time. They're designed to stay wet for 10 minutes, and we only keep them on the surface for a couple minutes, then they're dry. They're only allowed to be sprayed according to the EPA label so they'd be effective. And you need to spray them and let them sit for 5 to 10 minutes. So it'll actually kill the organisms you're trying to eliminate. But people are not using them appropriately, and many of them are not effective against biofilm or simply are not used on floors. So this is a huge failure point in the industry. And one of the last problems is the cross-contamination. Many times, you know, I can tell you working as an employee in a hospital laundry or in a long-term care laundry, you know, a lot of times we're not washing them at a high enough temperature. And a lot of times the laundering process is actually more problemsome than the actual solution they're trying to create. They're creating an environmental issue with the laundering of these mops and cloths, and a lot of times those mops and cloths come out of these laundries still contaminated. This is actually the graph you see is actually a Boston hospital that after laundering, we showed how many pathogens were present. Hand hygiene. So a lot of people focus on hand hygiene compliance, how many times and when we're washing our hands, but you know, this was a study that was done, and we worked a lot with Dr. John Boyce out of Yale, who was kind of the godfather of hand hygiene. And amazingly, we found in a healthcare setting, less than 50% of the backs of the hands are being washed, the fingertips, the thumbs. And, you know, how do you eat food? How do you perform care? How do you do any task? It's all fingers and thumbs. And so competency of hand hygiene is critical. So, and then, you know, the air component is pivotal, especially with COVID. You know, there's multiple studies that show, you know, the spread and the rapid nature, but I found this is actually a graphic picture. The yellow is someone sneezing. This is an MIT study that shows that, you know, organisms can suspend in the air for minutes and can travel up to 27 feet. In a Harvard study, it showed that COVID can stay active in the air for several hours. Again, as I talked about, you have dust, you have these recirculations, people moving, air movement, things can be recirculated, pulled into the HVAC and redeposited throughout your building. And finally, bacteria, because of all these challenges, housekeepers aren't getting the surfaces, HVAC systems aren't properly mitigating the challenges of COVID and these other organisms. And these bacteria can rapidly regenerate and recreate themselves. And many times within 6 hours in this study showed they're almost back to the same level. So a lot of the science, a lot of the research, and what you're going to be talking about in the next series is how do we mitigate continuous disinfection? How do we get to the point where, you know, these episodic things that we're doing are actually making a difference? So the solutions that we need to be looking at really need to be a recipe. You know, when, you know, you're baking a cake, you need the exact ingredients, the exact ratio at the exact time in the exact order. And, you know, cleaning and disinfection, you need to look at the surfaces. You need to look at hand hygiene. You absolutely need to look at the air. One of the biggest challenges I've seen as a former facilities director and doing biological testing throughout North America is the air challenges that we face, and they're not being mitigated, and it's a big gap. Water and waste are also part of that process, but we need to look at people, process, and technology. We need to measure, evaluate what we're doing and create those solutions. So the foundational solutions, if you click that again, you'll see that we require really the right people, the right process, and the right technologies. Certainly there's the disinfectant wipes, you know, sporicidal disinfectants, you know, single-use microfibers to eliminate that cross-contamination. Visual and biological inspection, understanding what's in your environment, where it is, if you have an outbreak, biologically understanding where it is, where it's not, and what processes are working, and what solutions are actually working, and then having training and certification continuously to mitigate these challenges. Those are the foundational solutions. And then we have what you call enhanced disinfection. And this is a whole category that is extremely powerful and sometimes misused. You have electrostatic sprayers, and you know, there's an old generation of these sprayers that are not giving you good information. They're not giving you real-time, you know, computer-aided feedback as to whether they're actually spraying enough and where they're actually doing it. UV disinfection, actually going through and using these UV lights to episodically disinfect the rooms. And both of these solutions are great for helping to mitigate all the challenges that I faced. Disinfectants failure, housekeepers not getting all the surfaces, all these challenges that we have. But the next solution is really what, the next slide. The next solution that we're talking about is really where the industry is moving. If you talk to the top infectious disease doctors throughout the world and the professionals that are understanding, it's enhanced disinfection that is truly going to help us get to where we need to be. Because when you're cleaning, when you're disinfecting, whether you're using these UVs and electrostatic sprayers, they're all powerful, important tools in our arsenal. But enhanced disinfection, such as ActivePure, is a technology that really replicates what's going on in the environment on a sunny day. So the continuous disinfection process can reduce active pathogens very quickly, up to 99% or greater on all the surfaces. And, you know, you have antimicrobial surfaces, you have, you know, like ActivePure oxidizing molecules that can be HVAC based or can be standalone units. And these are a powerful asset in actually driving down the risk that we're facing, both for COVID and these other organisms that continue to plague our long-term care facilities. So very quickly about our organization, we are environmental infection prevention experts. You know, we serve over 500 hospitals throughout the United States. 2,000 retail operations. We work with professional sports teams, really to educate and understand and help people to understand what's going on in these environments. Next slide. You can see we go through very quickly a comprehensive assessment that looks at biological testing of the surfaces in the air. How do you know what the challenges that you're facing unless you truly understand what is on those surfaces biologically? Because visually, as we talked about, is not enough. Staffing and productivity, are you using the right procedures? Are you training appropriately? What's your quality improvement and your regulatory compliance? And those all lead up to the next slide, whereas you get a comprehensive evaluation. Next slide, please, where you actually look at the biological testing and the outcomes all together to understand where your challenge is. Is it the elevator button? Is it the cafe tables? Is it the patient or the resident bed rails? Where are the challenges? Are they on the surfaces? Is it in the air? And what type of pathogens are actually being a challenge in those areas? So that turns us to the Q&A. Thank you for your time.
Thank you. Thank you, John. And as John was saying, please put your questions in Q&A. We have several questions already. I just have a question for John, because you started off by talking about that slide that said the tragedy leads to change, and you used 9/11 as an example, and that is absolutely true. Have we seen much in the way of change in taking care of these environmental problems, especially in assisted living? I mean, you get around to a lot of healthcare facilities. Yep. Are they actually changing? You did mention the fact that everyone's talking about and installing enhanced disinfection that is continuous for air and surfaces. But what are the changes you've seen, if any?
Yeah, no. So I think it's been a little bit of a mixed bag. I think everybody in their good intentions are trying to do the right things, but there's a lot of sometimes inaccurate information, whether it be disinfectants that you see on TV that have antimicrobial activity for a long time, or different technologies could be disinfectants, whether they work on that exact surface. So I believe we're starting to move in that right direction. I've seen it more in the acute care space. I think the long-term care space is I'm starting to see those impact. But I highly encourage everyone to really closely look at who the experts that you're aligning with, make sure it's science-based, make sure it's fact-based, because there's a lot of misinformation. You need someone with a fiduciary responsibility that can represent you in your best interest, and more importantly, the residents' best interest, because they're so vulnerable in this process.
Yeah. There's another question from me for both John and Dr. Birx. A lot of assisted living organizations are not particularly flush with cash. These are not like large hospitals. So what are the few things that they can do that will really have an impact?
Well, I'll go really quickly, and then John's the expert in this area, but I think what we've really known is you have to find solutions that are not human-based, because our human capacity in nursing homes and across our healthcare industry, there's just not enough human capacity. And so the answer can't be more people. The answer has to be using technology in new ways. And I think finding a solution that's continuous and effective across the pathogen spectrum, as John just spoke about, that's effective in air and surfaces, effective continuously, and effective against multiple pathogens, including the ones that are harder to kill, like MRSA and fungus. So COVID happens to be at the easy to kill side. You still have to kill it. But I mean, you want to find a solution that will work for COVID, but you want to find a solution that works for these other pathogens too.
I think it's a perfect, Dr. Birx, you're right on, spot on, is we have a problem finding restaurant workers. We definitely have a problem finding cleaners. and laundry workers. And, we need to find those solutions that are continuous and actually don't take that human capital, because a lot of the clients that we work with are dramatically short, sometimes by 30, 40%. So you can have the best tool in your arsenal, but if it becomes the elliptical, like in your room where you hang clothes on it, it doesn't work if you don't actually use it. So there's, and the other part of that is really understanding what's going on. Every building, every structure, because of the age, the performance, and what's going on, what processes they're using are going to be different. Assess what's going on, understand what's going on, and you can create very cost-effective solutions.
Dr. Burke said something that just reminds me again of, John, your statement about tragedy leads to change. I mean, the change is not necessarily simply making sure that we don't face the kind of pandemic that we've had with COVID-19. That is to say, it's not exclusively COVID-19, but it can lead to change, and it is leading to change that is increased consciousness. It's based on an increased consciousness of the problem of pathogens especially in our interior spaces. And so if we do a good job here in mitigating COVID-19, we'll also be mitigating a lot of other very, very dangerous pathogens. Is that right?
Yeah, I mean, it's absolutely a challenge that, COVID has brought to light, and very much like the tragedy we talked about, it's brought to light that we're deficient in a lot of these, superbugs. MRSA, C. diff is very much a problem in our skilled nursing and long-term care facilities. I mean, they run rampant. In norovirus, the stomach and the flu, in upper respiratory, all these things are dramatic impact points. So you're right. We have to address COVID, absolutely, but we also, in the same time, can address these other problematic points and create a much safer environment for our residents.
And Dr. Burks, one of the things I've heard from you is that the SARS-CoV-2 virus is relatively easy to inactivate compared to some of the other pathogens that John just mentioned. Is that right?
Yeah, so I think, when you look at the scale of ease to inactivate and air and surfaces, some of these envelope viruses are at the bottom, flu, COVID, in the ease to kill. But we can see how how transmittable they are. So when you have ease to kill, but very highly contagious, then that's the moment of really determining how you can actually stop these transmission. And now that many of us that are vaccinated and unknowingly shedding, I mean, before it was primarily the individuals under 35. And so really getting them tested. But now almost all of us that have been vaccinated may also have subclinical infections that are subclinical for us, but we're still shedding viruses through the front of our nose. And that is what is the most dangerous to our long-term care facilities, is these silent infections that are difficult to detect. I'm hoping that along with this big change, we definitively diagnose respiratory diseases, because we've made a lot of assumptions about how flu is spread or not spread, but we never tested for flu. And so there could have been people that had subclinical infections. I'm hoping that this changes how we look at biological cleanliness and how we look at definitive diagnosis. We should never be presumptively diagnosing flu or COVID or RSV or any of these diseases.
So in an assisted living facility, should there be a consistent program of testing, whether people have symptoms or not?
I think this fall is going to be a real challenge for our assisted living facilities that, are above the Southern Sun Belt. They already suffered that, and they lost, yes, they'll probably lose 8,000 long-term care facility residents. They lost 22,000 last year, so less. But we're at a point that losing anyone when we know that we have the technology to do things differently and we've learned enough about this virus to prevent it with new technologies. I think that's really absolutely critical. The thing with testing, just to be clear, if you're even testing twice a week, that person could have turned positive overnight, and then they're not tested again for 3 days or 4 days. They can be transmitting that entire time. And so this is the problem with silent spread. By the time you've detected them as test positive, they could have been spreading for days, because people without symptoms don't know when their start point was. And that's what makes it so much more difficult with these viruses that then spread silently. The nursing homes have really, I was in one 12 hours a day with my father for 6 weeks. They've done almost everything that they can with cohorting with the personnel that they have. We need to make it easier for them to protect residents and the workers with something that is done automatic and continuous.
So Dr. Burke, your comments actually fit very well with the question that we have. What is the length of time that someone is contagious prior to testing positive? So what's the look back from the last day that an employee worked that would not initiate an outbreak? If someone hasn't worked in, let's say, 3, 5, 7, 10 days, when they might not be considered, would they be considered an exposure to the facilities? He's saying that the Department of Health is very, I guess that's Michigan, is very inconsistent with the guidance on this. So do you have any guidance?
So this is tricky because we know with symptomatic individuals, they're shedding virus for at least 48 to 72 hours before they notice they have symptoms, which triggers the test. So it depends on how frequently the nursing home is testing and how many people are vaccinated, because we now know that a lot of the vaccinated individuals can also shed virus, even if it's the vaccine is 50% protective against any infection. That means 50% of your staff are not protective against getting transiently infected. And so if you're testing every 7 days, they could have been spreading the entire 7 days. And that's the issue. And we know that with vaccinated individuals, they probably shed virus a little bit less. So if the primary infection from case defined, and that's symptomatic people who are test positive, that's a 10-day window. For those who are asymptomatic, they have that same 10-day window, but you don't know when you detected them within the testing window. So that's a problem. And then the third problem is the number of people who have been vaccinated, where 50% of them, again, may be transiently infected. They may shed for a shorter period of time. And so vaccinated individuals may shed for 5 days instead of 10 days. That data is still not completely available. And so that is what's putting everybody at risk, is people unknowingly transmitting the virus. The sick people go to bed and the sick people don't come to work. But if you think you're fine, you're coming to work, because staffing is critical in many of our assisted living facilities.
So again, that just keeps bringing up the question of testing. I mean, do you think everybody ought to be tested as soon as they get to work every day? Would that help? Like in the White House, you know what that's like.
Yeah, that would definitely help. But we didn't expand supplies enough over the last year to be able to do that. We were on track to do that. We were up to 2 million tests a day. We could have gotten, I think, to 5 to 10 million tests a day, where in these high risk areas, people could have been testing daily. I'll tell you what I do. I test before I expose myself to the vulnerable individuals in my family. I'm fully vaccinated, but I'm doing that. And that gives me more reassurance. So I do it before I walk in the door. I don't rely on tests that I had 3 days ago. And this is the real issue. We found that most of the spread in the nursing homes are, of course, they're coming in through the staff, but it's coming in through staff that weren't infected at work. They're infected in family and friend gatherings, because people assume that they're negative because they don't have symptoms. And they assume that they're negative because they've been vaccinated. Remember, that antibody that is responsible for preventing any infection wanes pretty rapidly. We know it waned very rapidly with the Pfizer vaccine and the J&J vaccine over 4 to 6 months. We'll see what happens with the boosters, but our antibody is not meant to stay at high levels. Our immune system works through memory. And so we get that small infection, our body turns on their cellular and humoral immunity and fights that infection and clears the virus. That's probably happening over and over again in vaccinated individuals, clearing the virus within 3 to 4 days, never preventing it from going into the rest of your body, into your lungs. But we should not be feeling like we're invincible because we've been vaccinated, because we may be subject to transient infections with SARS-CoV-2.
So another question, thank you. Another question that we have is, what are the top 3 things a facility should focus on when it comes to environmental contamination? And this person's really talking about kind of specifics such as hand hygiene, replacing string mops, routine cleaning and disinfection. John, maybe you should tackle that one.
Yeah. So can you repeat that question first? Because
yeah. So the question is, what are the top 3 things that a facility should focus on?
Yeah.
And these seem to be highly specific.
Yeah, I think it's, the number one thing is assessing where they are. So, the category is so broad. It could be their disinfectant, it could be their mop, it could be their air. But, and I know that's kind of a little bit of a hard answer, but to hear, but they need to assess what's going on to understand how to mitigate this challenge. And it always comes down a lot of times to cost. I can tell you in assessing some long-term care facilities, we found that they were overusing labor and products in certain manners that just simply weren't effective. So we were able to redeploy those to a technology that would be continuous and became more economical. So again, I think understanding biologically and understanding process-wise whether you're having effect, looking at your disinfectants and doing simple tests on whether the disinfectant is even viable. We find that many disinfectants in the industry, what the housekeepers are actually cleaning with on the floors, there's no disinfectant left in the pail or the bucket. So those are kind of the top things that I would focus on.
I'll tell you, some of the, I saw some experimentation or some data on these mops, string mops. Incredible. I don't know whether people still use those, but.
Yeah, well, they do. And, it's kind of World War II technology. And we need to let those things go away, because I can tell you that a typical string mop, are very hard to launder. And I can tell you several facilities I was in this week last week had millions of pathogens on them, and some of them had come out of the washer and dryer.
Mm-hmm. So here's a general question about what are the best options for improving air quality, and we've talked a little bit about that. But let me just change the question a little bit. The CDC talks a lot about ventilation, which is just the exchange of inside air for outside air, which you can do by opening windows. A lot of assisted living facilities can't do that. A lot of them don't have the best kind of ventilation systems. Is ventilation, maybe I should ask Dr. Birx this, is ventilation enough? How should we think about ventilation and other means of cleaning the air?
Yeah, I think this really gets to the heart of the matter, because ventilation is one thing. And I'll just tell you a quick story. I was in North Dakota, and I was talking about the CDC guidance and how we had to crack open windows, and they laughed at me. When you're from the mid-Atlantic, you can actually do that. When you're in North Dakota for 7 months out of the year, there's no way you can crack a window. And I think, and their feeling was they could never keep up with the exchange rate that is required to actually remove that continuous production of pathogens. And that's our real problem. If we didn't breathe, or if that person who was infected wasn't in the facility and remained in the facility and they ran through the facility, ventilation alone may be adequate to get through that. But to get to the exchange rate that they're suggesting is not, it's not possible in these facilities. And our exchange rates at home and in these facilities would take 2 to 3 hours to remove that pathogen. And that's with a single introduction. But that single introduction is continuous. And what we don't want to do is we want to be able to keep nursing homes safe and open. And I just want to emphasize again, the work that the nursing homes are doing to ensure families have access to their loved ones is so critical. And I didn't realize how critical till I went on the road and started talking to nursing home residents in June of 2020. And I think it's already very difficult to be isolated from the other residents and not being able to be in community spaces and with their friends that they've really grown close to. And excluding families, again, would be very difficult. So figuring out how to create this system that is continuous will be key.
And I think looking at, the air, fresh air is critical to the equation. And in understanding your HVAC, you bring your car in to be diagnosed to how it's running and tune it up. Your HVAC system can have unbalanced air from one room to the other. Certain ones can have, different air exchange rates. So understanding that is critical. And I think the point that outside air is very positive to bring in. That's the exact nature of the active prayer technology, is replicating that process that happens outside on a natural sunny day and creating that environment inside to keep these residents safer.
Thank you both. And we really only have a minute or two, 1 minute left. So I just want to say that we will be learning more about this issue on Thursday when we get together again, and especially supplements to ventilation. And I probably should just mention an amazing study that was published by the CDC of a classroom in Marin County, California, where the teacher was unmasked and unvaccinated, apparently unmasked, and was reading to students. Students were apparently masked, all of them, and they had tremendous ventilation. They had cross ventilation with rows of windows on both sides. It's very nice weather in Marin County. And as well as a device a filtering device. And yet 55% of the students in that room, and they were also separated by at least 6 feet, each of them, their desks, 55% of them became infected. So we need more. And so we now have a slide up about segment 2, challenges in long-term care facilities, a regional case study. So we have a study from a long-term care facility in the Southwest that is very interesting. And the panelists on Thursday will be Dan Marsh and Ron Payne. I hope you can join us then. Thank you for joining us today. And I want to thank our panelists, Dr. Birx and John LaRochelle, and certainly the Michigan Assisted Living Association. Thank you, Brenda Roberts, and thank you all for attending. We'll see you on Thursday. Bye.